Well, thank you. Good morning. And again, welcome to Newport Beach. I work on a daily basis with young children and some adolescents who have intestinal failure due to a variety of causes. And when Joan asked me to talk to the group today about recent advances, I thought maybe what would be most relevant is talking about the things that I think have changed our practice the most. I had a career where I was doing what I'm doing now. I was in industry for a long time, and then I've been doing this for another 8 years. And what I have done is simply identified 10 things we're doing differently now that I think are giving us better outcomes, better results, or among those 10 things are things that I think are coming in the future, but we haven't yet altogether implemented. So these are the 10 issues I'm going to discuss. I'm going to touch very briefly on them this morning. There's a discussion session this afternoon if any of you want to explore some of these a little further. One of the biggest changes, I think, is moving from having patients taken care of in general practice, in a GI practice, in a surgical practice, to actually being taken care of by intestinal rehabilitation teams. Depending on the focus of the hospital and the team, the personnel may be a little different from center to center, but almost all have surgeons, gastroenterologists, TPN nurse, pharmacists, dietitians, and social workers. And many other programs have transplant surgeons because they're fundamentally a transplant program as well. In pediatrics, we use a lot of occupational or speech and language therapists for the problems the children have with their food aversions. Psychologists can be extraordinarily helpful. We don't have the benefit of that yet, but we're looking forward to the day when we do. We do have a large cadre of child life specialists in our institution, and they in particular can make some of the procedures that these kiddos have to go through easier and, in addition, safer. I've seen children who couldn't tolerate having a tube changed and required anesthesia each time go to being able to manage a tube change without anesthesia because of the intervention of these skilled professionals. And patient educators, and in fact a nurse educator is the next hire on the wish list for our division. So these are all folks that can play important roles. I've recently been working on a paper looking at the effectiveness of nutrition support or intestinal rehabilitation teams. And there really is data now in the literature to support the work that we do. Survival's improved by these teams if you compare the experience people have published before they had a team with their experience after the team. And that's true even if the patient is not weaned from TPN, even in the presence of liver disease. What do the teams do differently? Well, they wean more patients from TPN. Central line infections have been reduced in a number of these programs. There's more frequent use of these varying lipid modification programs, including the use of fish oils. The progression of liver disease has been substantially reduced. There are more bowel lengthening procedures performed. Patients are more likely to be treated for bacterial overgrowth when they have it. And should a patient be on a transplant list, they're more likely to proceed to transplant. So these are substantial improvements brought about by a more organized approach to health care for the special population. Another innovation, I think, has been the use of locks, particularly ethanol locks. There are various protocols for its use. Different centers have somewhat different indications. We tend to use it in all of our implanted central lines now. There isn't a standardized protocol in terms of hours per day or number of days per week, but despite these differences, we've really seen dramatic changes in infection rates, particularly in patients who previously had frequent infections. So this has become an important part of what we do. I think there's enough evidence in the literature now to provide reasonable support. As with all advances, there are some potential concerns. The alcohol will precipitate with heparin, so you have to keep those two medications separate. There's some concern about catheter damage from the use of alcohol. It's probably not indicated in ports, but not everybody approaches that the same way. It's not usually used in PICCs because they're made from a different material that is thought to be less tolerant of alcohol, although the data on that are limited. And perhaps these catheters, especially if they're not infected, may not last as long. And I urge you to see the presentation that is going to occur during this meeting. Oley had the foresight to make this one of their research awards. So I'm very impressed with that work. Another area that's very mundane, but perhaps related to that last wonderful presentation that you heard, is to limit access to dangerous places. And here I'm talking about, in particular, our young pediatric patients. Their catheters and tubes are attractive nuisances. These tubes get pulled out. They get broken. People trip over them. And there are children who just get fixated on doing damage to their own equipment. And again, we have to find ways that the system that we use for their care makes it more difficult. So the catheters have to be taped in an appropriate fashion with all of the vulnerable part of the catheter taped such that breakage is less likely. We've increasingly been encouraging the use of vests to limit access in young children to their catheters and their tubes, and I really think this is beginning to be effective. Both at home and particularly in the hospital, we've been focusing on trying to keep the tip of the catheter away from an ostomy. This is something that I've more recently become sensitized to, but we're actually developing a bedside checklist that will make sure we are doing this on a consistent basis. And if we have a visible checklist on the foot of the crib and the parents see us doing this every day, then I think this will translate to improvements at home as well. So I think this is important. And we've been impressed enough by the existing data that we are using ethanol caps as well to help preserve the integrity of the end of the catheter. Now, other locks have been studied as well. Antibiotics are used both prophylactically to prevent infections and also therapeutically. In Europe, they have something called a Toro lock. It may have all or most of the advantages of alcohol without some of the disadvantages. There's pretty good experience in a number of population groups, and there's evidence it's effective. There's a meta-analysis that's been published. Unfortunately, this is a device approved in the EU, not in the US, and I haven't detected interest on the part of the manufacturer to bring it in, but maybe this will change. And then other compounds that are being used, you see on the slide as well. So this concept of putting something in the catheter that makes it more difficult for bacteria to grow, that breaks down the film that lines the catheter, seems to be an important advance in preventing infections in chronically indwelling catheters. Another area that I think is starting to make a difference and will in the future is vein rehabilitation, or reconstruction of occluded veins. You're going to hear a talk just a little later this morning from Dr. Frank Ng, who is the chief of cardiology at our institution and one of the pioneers in this area. And I'm not going to dwell on this today, but given that running out of IV access becomes one of the limiting factors for chronic home TPN and an indication for transplantation, if we can begin to take that indication off the board, then I think we have another very important advance in the management of home TPN. This next one is a bias. The data are pretty limited, but it is a very important part of our practice, so I thought I'd put it up here. Many of you are aware, and I think the use of blenderized feeds is part evidence of that, that fiber probably has an important role in intestinal adaptation. It may have a number of effects. It may slow emptying from the stomach and slow motility in general. It probably provides some nutrition indirectly to the bowel wall. It can provide thickening of bowel contents, so there's less water in the resultant stool. And almost certainly fibers and things that come from fibers alter the bacteria that live in our bowel and how they function. And there's a lot of interest then in that in regard to bowel function, including in short gut and in other forms of intestinal failure. I've tried using, I think, all the fibers that are out there in various contexts and have been fairly consistently frustrated with a lack of effect. I was talking to a colleague at one of the Aspen meetings a few years back, and he said, "Oh, we've been using green beans in this population." I mean, I know the guy's pretty respectable. It sounded pretty strange. So I took it home and we started doing it, and we've been doing it ever since. I've given you one reference here of some papers that were published of some cases that were published in NCP a few years back, and there may be other evidence as well in the literature, but we mix some green bean with the formula. We only hang it for 4 hours because of our concerns about sterility issues. But this has been effective in reducing the looseness, sometimes the frequency of stools, and allowed us to advance feedings more rapidly in some of these kiddos. I have very little experience with it in older patients, but I think it can be effective there too. So, fish oil. You are all aware of the excitement surrounding the use of intravenous fish oil alone or in combined oils for the management and perhaps the prevention of the cholestatic liver disease that occurs in patients on TPN, particularly in premature surgical babies. We have multiple case series now from Boston, from Houston, from really all around the country and the world that are experiential in nature, showing the result in the individual patient or the group of patients with the fish oil. We haven't had a lot of double-blind randomized controlled trials per se. There are at least 2 meta-analyses I'm aware of showing evidence that the direct bilirubin comes down with these therapies, maybe more so with the pure fish oil. That may help bowel adaptation and allow, particularly important, more time for the bowel to adapt. And this again is from the perspective of someone taking care mostly of young children, such that you don't have liver failure before you have intestinal function. And so we've been using this as an important part of our armamentarium in kiddos who start to get liver disease. Nationally, we see a substantial fall in the rate of intestinal transplantation or combined liver intestinal transplantation for the indication of liver failure in the context of short gut and intestinal failure. The FDA and ASPEN, and I know Oley was heavily represented at a meeting in 2013 in Washington. And some of the companies, advocates such as yourselves, and academics got together to take a look, because FDA was struggling with how to approve these fats, these lipids, and incidentally they're now available in Canada, which is I think a very good thing for part of North America. So IV fish oil and other oils containing fish oil are not available in the US, but they have been approved around the world in a number of countries, both the pure fish oil and the combined oils. There is a lot of patient experience. FDA's concerns appear to revolve around the emulsifier system, well, the phytosterol content that is in the soy emulsions, the limited quality of some of the research surrounding the studies of fish oil, and the lack of an internal regulatory path to approve products like this. You know, FDA has a drug side and a nutrition side, and this is smack dab in the middle, and they're struggling with this. And you see the same thing with probiotics. So FDA's guidance was that partnership is key. A group was formed mostly to advise FDA and try to get towards a guidance document on how these fats can be approved for the future in the US. I can tell you this is moving very slowly, but it's moving. In the interim, one new IV fat emulsion has been approved, but it's not one containing fish oil, and it, last I checked, was actually not available. Now, I mentioned FDA's concerns about study quality, and I did find a bright note in the literature. There's a paper coming out in JPEN using what's called SMOF, which is a combination of soy, MCT olive, and fish oil. This is a group that did what they called a pilot study in 24 infants with early intestinal failure, some abnormalities in their liver function, and they were randomized to SMOF or the existing lipid at equal doses. And even in this relatively small population, they did find that the bilirubin was lower and more kids had no direct bilirubin in their blood. So I find this encouraging because it begins to address some of the concerns expressed by the FDA. So the next area that I think is altering our practice, or will alter our practice, is the availability of hormones specific for gut growth. We've known for some time that breast milk seems to help bowel adapt, and many of us have become advocates of breastfeeding in children with short gut whenever feasible, probably because it contains growth factors, but maybe other things we don't fully understand. Growth hormone itself has actually been approved for short gut by the FDA, but has some notable potential side effects. More recently, GLP-2 or teduglutide has been approved for adult use, and it is now available. Pediatric studies are ongoing. There are other approaches being explored as well in trying to figure out how to make the bowel grow better in this special situation, both using drugs and even devices. If we look at the one example that's come to market recently, this is a slightly adapted form of a natural hormone that makes it last longer in the blood. And studies have been done in the adult population. The hormone mostly causes an increase in growth, but also slows gastric emptying and probably has some other beneficial effects that are still being worked out. But if we look at the clinical studies where patients on teduglutide were compared to controls, far more of the teduglutide patients had a decrease in their IV fluid, a decrease in the number of days of TPN, and in patients who received extended therapy, there was about a 10 to 15% incidence of actually coming off of TPN with those patients. Pediatric data have been published. They're similar, but work is still going on for the pediatric indication. There are a number of potential adverse reactions. It's a growth stimulant, so there is concern about any possibility of tumor growth, and patients are being monitored closely for those possibilities. One of the other approaches is to making more bowel is GI tissue bioengineering, where stem cells or a piece of the bowel or even skin cells are transformed into intestinal cells grown in a special fashion so that they make more bowel, and then that bowel can later be anastomosed to the existing bowel. These are approaches that are still, I fear, many, many years off, but the ongoing research is on the starting tissues and the cell lines, the growth factors that are needed, the matrix in which you grow the new bowel, and assuring that you have both absorptive and motility functions as well as anatomic structure. But it might look something like this, where a child has necrotizing enterocolitis, for example. The surgeons are there. There's some normal bowel, there's some abnormal bowel. They take out the abnormal bowel. They take the normal bowel, run it through a machine that turns it from bowel tissue into cells, put that on something like a Dacron matrix, insert that back into the abdominal cavity, give it some time to grow, go back, harvest a new piece of bowel, and put it back in continuity. Unfortunately, it's not that simple, but there are people trying to get us to the point where it is that simple. And Dr. Griekscheik, who works across the street from me, is one of the leaders in this field, and we were hoping to get her today, but due to her professional commitments and her skiing career, which got her in a lot of trouble this winter, she's not here. But this similar approach is also being explored for some other disease forms. For example, Hirschsprung's disease, or possibly some of the pseudo-obstructions, where the nerve cells that populate the gut, which are different from the nerve cells that populate the brain, can be grown from stem cells, inserted into the bowel, allowed to migrate, and then at some point they would have function. There's been a very technical and advanced paper just published in Nature on this, and again, this is far from prime time, but it is a wonderful example of where very future-oriented people are doing research. Another type of transplantation is not the bowel itself, but what lives in the bowel. And there is animal data showing that if you take the bacteria out of a congenitally fat mouse, put it into a thin mouse who doesn't have bacteria, and then watch it grow, it may turn into a fat mouse. So are there things we could do with our bacteria to make us gain weight a little easier. And in fact, there's one example, this doesn't project very well, but a woman had chronic Clostridium difficile infection, needed a fecal transplant as treatment for that, got a transplant from her daughter who was overweight, and this woman who previously had been normal weight became overweight after her fecal transplant. So it's within the realm of conception that some bacterial modulation could be in the role. And then I can't stress enough the importance of what you folks can do with and for yourselves. Locally, we have something called Supper Club and Snack Pack, and have the occasional family picnic where folks generate a lot of ideas, a lot of family support, a lot of education for the kids that are involved. Participation in groups such as Oley is, I don't think I was sensitive to this before I came back into my current role, but it's just horribly important. And you've already heard the importance of political action, and there's plenty for us to be working on. And then just a final word on maybe some of this is preventable. With genetic counseling, we may be able to prevent or alter the course of some diagnoses where we know the gene responsible for them. There's some evidence that there is something special about pregnancies with gastroschisis, and perhaps early interventions can make a difference. And then we have a whole literature on the use of probiotics to prevent necrotizing enterocolitis, and the neonatologists are trying to figure out how to make this actionable. So I'm going to stop at this point, I hope on time, and thank you for your attention.
Thanks, Dr. Merritt, and we'll take any questions if anybody has. Just, we're getting the microphones to you right now. There's a question right here.
Yes, Doctor. Excellent presentation. I thought you hit the right level for this audience. A practical question. In terms of these teams that you talk about, there are very few areas, I assume Omaha and Mount Sinai and probably UCLA, where you have a team that can do that. Are you just talking about for initial evaluation? Because how do people such as us, as patients, ever garner a team like that? It almost seems impractical to be able to get that kind of support, which I think we would all like, and it sounds like the gold standard. But you know, how can we do that practically?
Well, I think it's becoming more generally available, particularly in the large cities. I would say that patients that are taking transplant programs and programs that take care of large numbers of folks with intestinal failure, I think have found this the most efficacious and maybe the most efficient way of helping patients. I don't think this is going to, probably shouldn't occur in rural America, but in those of you who have access to some of the larger or even intermediate size medical centers, particularly in pediatrics, maybe a little less so on the adult side, I think there are enough advantages that you may want to consider at least getting some guidance from one of these centers. I think there are a lot of patients. You mentioned some of the biggest centers, and I think they follow a lot of patients from different parts of the country, not on a daily or a monthly basis, but twice a year or something like that, and you can get the advantage of their expertise that way.
Over here.
I just had a follow-up question to that, because what I've seen, we came from a regional hospital originally and then transferred to a hospital with an intestinal rehabilitation center. And from what I've seen, that there isn't always a transparency for certain hospitals indicating that they don't have an intestinal rehabilitation program, and that those programs are available and could potentially be available to some consumers. And I don't know what could be done to substantiate some of these programs in a way to dictate or quantify them as having a higher level of care to be able to facilitate transfers for families who don't have access to these programs in their local areas.
Well, I know one of the professional societies is working on a statement about the role of some of these teams, and I think that becomes valuable at some point relative to influencing insurance companies and you know, whether they're willing to support center care, that type of thing.
Okay, I just wanted to let everyone know that we are going to be working on creating an area on our website that identifies the clinicians that have some experience with managing nutrition support. You will be able to identify the programs. However, we are not endorsing one or another because some private clinicians provide very, very good care. So, but it will just be a resource, a go-to list to help you navigate your choice.
I have a question on the fish oil. It sounds like they're giving it to pediatric patients for liver failure. How about for adults?
There's much less experience with it in adults, but there are some case studies showing its effectiveness. We've treated 2 adolescent patients who had really chronic cholestasis, and both had a very substantial and beneficial response. So it is feasible. I think there's a little less clarity in my mind how to dose it in adults, and I would like to see more work going on in that area. Perhaps when we get to the era of having a broader range of lipid emulsions available, we'll then see more opportunity to get the answers to these questions.
Okay.
Yeah, I have a quick question too, and it's sort of twofold. You were talking about the green beans as being used to, help with the gut, and so is that a commercial product available that you guys are using, or just green bean baby food? And then the second part of that question is, any experience usually using the banana flakes which is available as a commercial product?
Yeah. When I first came back to my current hospital, we had a dietitian wedded to banana flakes, and so we have used those, and I think with some benefit. The preparation we have been using is the little 4-ounce jars of pureed green beans from the baby food manufacturers, and we haven't come across other sources. In our older patients, we encourage the consumption of the beans themselves, and in the kiddos and the patients on tube feedings, we have been just adding some puree to their enteral feed.
We're going to hold questions there. If you have any other questions, you can talk with Dr. Merritt later on today.